Welcome everyone to the Sudanese Infectious Disease Association Grand Rounds. It's my great pleasure today to introduce our esteemed speaker, Dr. Hamad Abdelhadi. Dr. Abdelhadi is a senior consultant in infectious diseases at the Communicable Diseases Center of Hamad Medical Corporation in Doha, Qatar. And he is also an associate professor of clinical infectious diseases at Qatar University. He's also a fellow of the Royal College of Physicians in the UK with an MBBS and a diploma in HIV medicine and a master's. Dr. Abdelhadi brings a wealth of expertise and experience in clinical medicine and infectious diseases. He is deeply committed to medical education and plays a vital role in the training and development of residents and fellows in his field. In addition to his clinical work, Dr. Abdel Hadi is actively engaged in academic research, leading several funded local and national projects that focus on the critical issue of antimicrobial resistance. His collaborative work with both national and international academic institutes highlights his dedication to advancing our understanding and treatment of infectious diseases. Please join me in welcoming Dr. Abdel Hadi. Floor is yours, Hadi.
Shukran Azadin for the nice introduction, and thank you for all colleagues who join the webinar, which is our monthly meeting in SIDA, to try to exchange experience actually. Today I'm going to talk about this untangling the interface of diabetes mellitus and infectious diseases. And to start with, last April I was in ICMID in Vienna in Austria. And following the conference, actually, I sort of doing a short trip to nearby sort of cities, and I went to Budapest in Hungary. As you know, it is lies in the Danube River. There is few capitals in Europe and maybe 7 cities lying in the Danube. And despite the nice landscape actually of the Danube, and you can see all these bridges, it still, bring the sort of unsettlement what happened in Sudan. This is all the bad memories of the war, because Budapest as a city itself has a very sort of significant landmarks of war. Because when the Germans were retreating actually from Europe across the Danube, they sort of bombarded all these bridges, as you can see, and it took them 10 to 20 years to rebuild them. And just to show you the devastation sort of consequences of war and how war affect nations. And I hope in our country, in Sudan, we can overcome this uh, one day. Again, Hungary is the sort of birthplace. They have a street in Budapest called the Boulevard, where there is 7 scientists who had awarded the Nobel Prize in medicine and science. One of them is this Albert um, Girogiri, who's the one who sort of done the Krebs cycle and the sort of vitamin C. And he had a nice quote actually, which I use actually close to my heart. Defining research, he said, research is to see what everybody else has seen and to think what nobody else has thought. So I'm trying to take some of his sort of quotes in today's lecture. The objective of the lecture is to explain the susceptibility of patients with diabetes and infectious diseases, which is very solid and very well known to most of you actually. And then to raise awareness of the close interface of diabetes and infectious disease, familiarize the common infectious diseases specifically associated with diabetes, and then to explore potential research venue between joint specialties. And the method which I'm going to, or the approach, I'm going to go to back to basic to talk about the triad of diabetes, immune system infection, and understanding the pathophysiology. And then I will use report from international organization and scientific institutes and data using evidence-based medicine. And then I will going to have some other clinical part. So I split the talk about science and clinical, because I know the clinical scenarios are very close to most of you. So the first part will be the science. The second part will be the clinical scenarios. And then I will finish with a summary. I start the debate actually, is diabetes is triggered by infectious agent? Okay. So as you can see, any disease to happen, you have the intersection between the pathogen the host, the environment. And some people suggest the presence of co-infection, like microbiota, for example, in the middle or colonization. And then the intersection of all this will bring disease. So if you put a hypothesis that type 1 diabetes is a viral infection triggered by a specific autoimmune pancreatic disease leading to insulin deficiency, that is a very well-established hypothesis. And there is so many suggested agents, including enteroviruses, the herpes, or the chlamydia species, or even bacteria. And then in type 2 diabetes, it's a chronic inflammation, which is leads to the production of inflammatory cytokines, which eventually cause insulin resistance. And if you search this hypothesis, there is a lot of research to support that, as I will show you. So in the left side, in type 1 diabetes, the hypothesis that is the antigen presenting cells, they are infected with a specific antigens, and then they present this to regulatory T cells. And the regulatory T cells eventually adapt, as well as the CD4 cells, commandeer the CD4 cell, which is an integral sort of cell in the causing pancreatic diseases, has been isolated within the pancreas. And that is will cause significantly lead to pancreatic islets deficiency and eventually in insulin sort of deficiency and the precipitation of type 1 diabetes. This hypothesis is very sort of, if you look at it, it is quite plausible because you just need an antigen, an infectious antigen from the pathogen, which is cross-react with the pancreatic cells. On the other side, on the right, type 2 diabetes, there is a viral infection, either cause chronic pancreatitis or cause immune activation, leading to cytokine production. And this cytokine, there is very well sort of sought research talking about the cytokine and increased insulin output and insulin resistance. And this vicious cycle will produce type 2 diabetes. Of course, to have either both of type 1 or type 2, you need to have the genetic susceptibility, as I will show. And the hypothesis have like 5 dimensions. Is there is direct infection of the pancreatic cells by an infectious agent, which is could be sort of virus or bacterium? Or is it a bystander activation, antibodies produced to kill the antigen from the virus, leading to the pancreatic cell dysfunction? Or it could be working at the level of the messenger RNA. These particles eventually coalesce with the inside the cell and leading to dysfunctional cells. Or it could be molecular mimicry, where the antibodies produced against this antigen again activated T or B cells and eventually lead to pancreatic disease. And it could be sort of persistent infection and eventually leading to the development of diabetes, like in type 2. And in type 2, on the right, you have the environmental factors, for example, increased dietary intake of high fat and glucose diet. And you have the genetic susceptibility to the right. And then you have the 3 function of the liver, the adipose tissue, to the pancreas. And this is production of the cytokines, a lot of, and eventually that will cause to increase insulin resistance. And there is a lot of sort of research done into this to try to explain that. Um, to explain this sort of scientifically, for example, the health impact of 7 herpes viruses in patients with prediabetes, this is called the CORA cohort in UK. So what they have done, in the population, they looked at 1,200 sort of participants and the risk of development of type 2 diabetes. And then they looked at patients who have incident of diabetes, like 30 of them, okay? And they followed them over time, over almost 7 years, and they have an entry sort of antibodies, and then they looked at patients who developed diabetes to see which one they were positive for a specific, so like an observational study, as you can see. And they studied herpes viruses because herpes viruses are one of the viruses which has been sort of postulated to be associated with diabetes. So what they found on the cohort in the patient who developed diabetes on the right side, that the antibody for herpes simplex virus type 2 and both for CMV is elevated in patient who had diabetes. And this all small sort of marks, this is adjustment for many confounder, including sort of age and sex and other confounders. And across all board, they found this patient actually they are increased risk. And because it is an observational study, unfortunately, it's not a causation. Just all they were trying to say in patients who develop type 2 diabetes over time, they are more likely to have antibodies against HSV and CMV. But it's an observation actually, and I will delve into it. And then we talked about the pathogen. This is potential like the herpes viruses. Let us talk about the host. And again, we know from our science the host definitely implicated in diabetes. HLA 24, HLA 18, 39, 24, all have a strong association with type 1 diabetes. And there is association also with type 2 diabetes. And the postulation that is the activation of the immune system through a specific antigen in a susceptible host will eventually lead to development of diabetes. So from this paper, for example, then, which is in the Journal of Clinical Investigation, September 2024, they looked at specific epitope from Klebsiella, which was stimulating and cytotoxic to pancreatic cells in patients with HLA-24. This is a group from Cardiff. So they found this epitope, they sensitized the lymphocyte, and when they subjected to the pancreatic cell, it was cytotoxic to it. Okay, so an interesting observation in their postulation that is the Klebsiella, which can be present in the gut or the like a microbiome or like a gut commensal, it can trigger the development of diabetes in susceptible individuals. So you have to have the susceptibility of the individual. So I know a lot of you might say this is a hypothesis, a lot of research, we cannot explain that. I will bring you actually to the story of both idiopathic, which we call it in medical school, idiopathic thrombocytopenic purpura, both ITB and TTB. And these are conditions where you have thrombocytopenia and thrombosis not explained by science at that time. So it's all about idiopathic. And what happened, as you know, you've seen the output of the COVID pandemic research, produced research like never before. And we are actually lucky in a way to live the history of the COVID because it was great for all of us. And if you remember, if I bring you to this is April 2021. Mustafa and others might remember that vividly in Oxford. So the Oxford vaccine, the AstraZeneca, to use a vector, they used a defective adenovirus from chimpanzee, which is defective. That means they took the DNA of it, but it was a DNA vector. While Johnson and Johnson use adenovirus 26 as a vector to deliver the surface protein. And in UK, because you introduced the AstraZeneca first, there was cases of thrombocytopenia and thrombosis, which is puzzled a lot of hematologists. A patient develop both thrombosis and thrombopenia. And as you know, this is very well validated cause immune related thrombocytopenia and thrombosis. And what they found actually, there is a very sort of specific uh, platelet, factor 4, which is cross-react with the adenovirus, okay? So it became apparent now, this is very well-known fact actually, both TTB and ITB are very related to adenovirus infection, okay? So this idiopathic part of the disease was almost taken. And if you remember for our clinical patient with ITB, sometimes they have exacerbations, which is happened to them every now and then, nobody knows. And most likely this was precipitated with adenovirus. They have the adenovirus infection and the thrombocytopenia, the production of antibodies. So what I'm postulating, I'm almost convinced actually, if I'm younger, I would have done a PhD on this actually to look at the effect of diabetes triggered by an infectious agent because it is very plausible from the host factor, from the pathogen factor. It's just to try to find. And the implication of this actually in clinical science will be huge because you might reduce vaccination for a susceptible individual to prevent the development of diabetes. That brings us to the why patient with diabetes, we've seen them actually, there is susceptibility to infection. It is multifactorial. Patient with diabetes has neutrophil dysfunctions. They have a compromised adaptive and innate immunity, main lymphocyte and the macrophage dysfunction. And then they have problem with the leukocyte recruitment inhibition, and they have the defective in the pathogen recognition. And then the main cytokines production, like interleukin 1 or TNFs, are defected. And the antioxidant system also in patient with diabetes. That's why it's a multifactorial, and it could be mechanical or it could be cellular. Because patient, they might have a tissue damage, for example, atherosclerosis, which will reduce the immune cell access to tissues. Or it could be metabolic stress, hyperglycemia, acidosis might affect T cell functions. And it could be hormonal dysfunction, immune cell problems, or it could be metabolic imbalance because of the high lactate, for example, leading to cellular dysfunction, or it could be hyperglycemia. And all this sort of macro and micro as well as cellular level of diabetes predispose patient to not only that, with our colleague in Weill Cornell Medicine and Dr. Muhammad Bashir from craniology, we're raising also the question, does patient with diabetes have a different microbiomes? And that is very well studied. Patient with diabetes has different microbiome, and maybe this microbiome will make them susceptible to infection. Okay, and then the autonomic neuropathy, we've seen it actually affecting the mucosa and the skin, as we can see in diabetic septic foot later. And then you have both at the cellular level, the innate and the adaptive immunity both affected. And these all contribute to infection. Not only that, if you come at the pathogen level, for example, we know that Staph aureus is a very aggressive, causing severe disease, skin and soft tissue infective endocarditis. Why Staph aureus is very pathogenic? People studied the metabolic pathways, which is the glucose dependent in this all sort of bacteria. For example, they found Staph aureus have 29 pathways compared to Saprophyticus 21, Hemolyticus 20, Epidermidis 16. So epidermidis are the less virulent because have the least metabolic glucose dependent pathways, which is very interesting actually. And the other side, in group B streptococci, some studies found that actually the hyperglycemia in patients with diabetes increase or induce the virulence factor on GBS, as we see. As you know, group B strep can be a commensal in almost 1/3 of humans, including females, without causing disease. What shifted from commensal into pathological? It must be virulent factors. And they found actually hyperglycemia integral into moving the GBS into, and that's why patient with diabetes in all cohort, actually, we've done a study in group B strep bacteremia, 1/3 of the cohort are diabetes. So we know that diabetes is very integral in causing GBS disease, and we've seen it actually in skin and soft tissue infection in patients with staph. And this susceptibility, not only at the level of the host patient with diabetes, they have a lot of problems, as you already, they have microbusted, increased heart problems, they have stroke, they have kidney problems, they will be in ICU, they have organ transplant, they have hemochromatosis associated with end-stage renal disease, ketoacidosis, and all these conditions predispose them to many organisms, aspergillosis, for example, pneumococcal infection, as I will show you later, and HSV, rhinosinusitis, and mucormycosis, as I will call you. So the comorbid condition of patient with diabetes predispose them to many pathogens as a secondary complications. The association about the glycemic control and chronic infection in people with type 2 diabetes is sort of very well documented. This is I try to convince our group here. I'm trying to build diabetes and infection network, including with Qatar University, but unfortunately, people if not are not paid, they're not staking in. It's difficult to do that. So this is a very simple cohort study in the UK. They looked at 35,000 patients with type 2 diabetes compared with almost double the number without diabetes. And they looked at stratification. This is a control and group disease infected. With the type 2 diabetes stratification, patient who had a good control, hemoglobin A1C less than 7, moderate at 7 to 8.5, or poor more than 8.5. And then they looked at the incidence of infection. I think it is not surprising to you that all patients with diabetes, even if you correct that with confounders, that increase infection. And the most common infection are influenza-like illness and pneumonias, as well as skin and soft tissue infections, urinary tract infection, and genital and perineal infections. And this is very well known to us. We see patients with diabetes are more likely to cause infection. And the odd ratio for all this almost double in most, which is statistically significant. So even from observation and study, you can say that patient with diabetes at increased susceptibility to infection. And we've seen that in the COVID. I remember the first report, which is came from China following the epidemic, looking at risk factor. There was old age and there was diabetes. That is was very evident. I gave in our last conference actually the all I can do similar lecture in the future about age and infection. And again, it opened my eyes to a lot of things. Patients as old age have chronic inflammation, also predispose them to infection. The same thing, this patient with diabetes, in the United States, they looked at 2.5, 4.2 million diabetes related deaths. There was 30% surge in diabetes related deaths during the pandemics. And I'm sure you've seen it. And we've done a review, I remember, about COVID. And we looked at this is specifically why patients with diabetes are increased incidence of severity of COVID-19 disease. And that is led eventually to their admission to ICU, very well documented in observational studies, as well as increased mortality. And as you can see from this, uh, in pre-2021 and after sort of 2021, there is increased incidence of diabetes related deaths during the COVID, which is interesting. One of the also interesting part, I think many of you who work in the Middle East look at the association of diabetes with TB, which we call it the immunological mechanism of contributing to the double burden of diabetes and intracellular bacteria. So if there is organism which is intracellular, yeah, as you can see to the left hand side, which is, for example, in a granuloma, and the granuloma, as you know, it is functioning with the macrophages, with the lymphocyte, and it is maintained by the cytokines. So this is very integral. The cytokines are very, and that's why biological treatment, for example, anti-TNF, will disrupt this macrophages function. The same thing in diabetes. All the T helper cells, the cytokines are affected. So the patient with diabetes, they have inability to contain pathogen which is intracellular. And the two good examples are Mycobacterium tuberculosis and Burkholderia pseudomalii, I will show you later. So this intracellular sort of organism, the diabetes cannot control them. And what that leads to, that patient with, we know when you have a latent infection, usually the sort of exposure is about, patient 10% develop active disease, 90% go into latent. We know that patient at diabetes more likely to have active disease, more likely to have reactivation, more likely to have sort of extra pulmonary lesion, more likely to have relapses, 20% as of 5%, and more likely to suffer from this. And this is, again, I will show a study later about diabetes and TB. So the link about intracellular pathogen with diabetes is there. And I'm already sort of alluded to that diabetes affect activation of TB, recurrence, and death from TB. All this is accelerated in patient with diabetes at many front. And this being recognized in the global TB report from 2024 from the WHO about risk factor for uh, diabetes, for TB. They put malnutrition number one, alcohol, smoking, HIV, and diabetes. I'm working here actually in Qatar, and I can tell you, people looked at the HIV epidemic in the 1980s and 90s as the main drive of TB in Africa. The main drive of TB in patients, especially from Southeast and mainly from the Indian subcontinent, is diabetes. Almost 30, 40% actually of patients we diagnose them with new diabetes, with new TB, they have diabetes. Okay, so it's very interesting, and it is became part of us as the audit standard that for all patients with TB you have to test for HIV. Our audit is standard to test for diabetes with hemoglobin A1C or fasting glucose on all TB patients, because there is the chance of finding TB is almost 30-40%. Um, I'm not sure whether Khalid Dosa with us, but before he left to Cleveland, he done a study with our colleague Abdurrahman Hamad, who's a senior consultant now. I think this was published in 2018, if I'm not mistaken. They looked at 134 patients with diabetes, and they matched them with 134 patients without diabetes. Because our patients are lean, actually, diabetes in patients from the Asians are their BMI is not different, symptoms comparable, but when they looked at their sputum, the patient with diabetes are higher, and this is as evident by alcohol and acid fast bacilli in the sputum. And they have less cavitatory disease, more cavitation and immunocompetent. You might think about immunological factors. The smear positivity is higher in patients with diabetes, with statistically significance, odd factor almost 2.3, and hemoglobin A1C was usually at diagnosis. But what is interesting that, as I already mentioned, about 30% of patients with TB were also diagnosed with diabetes at the time of diagnosis. And this study, Khalid and Abdurrahman study is one among many. There is 44 studies, 4 prospective, 16 retrospective, 17 case control from 60 million population of 16 countries. From the prospective study, the odd ratio of diabetes and even 3.5, retrospective case control. So generally, people, we say actually averaging about the odd ratio of 3 if you patient with diabetes. And I asked our endocrinology colleague whether they screen their patient with diabetes for TB. They don't have that routinely. And, two of my colleagues already sort of doing some parallel studies actually to try to see whether we can screen patient with diabetes for TB, either for with quantiferon or with chest X-ray. And it's interesting. And the problem, because it's screening, you need large numbers to prove that. But one of my junior colleagues, she think there was a lot of patient with diabetes might harbor TB and undiagnosed, and this is eventually will be revealed in few years time. So another area I think you already seen is the skin and soft tissue infections, and you've seen boils, carbuncles, and abscess. And this is again multifactorial. It can be external, like in the left-hand side, where you have breakage of the skin or the mucosal bridge, entry of the pathogen, which will find an optimal environment of hyperglycemia and non-functioning immune system, and eventually this is within few days go into a very severe infection. Or it could be hematogenous, which is usually deep, as you see it in necrotizing fasciitis, and the deep infection will be more devastating because it starts very low and then goes up with many consequences. And as you've seen in necrotizing fasciitis, is more severe than the superficial infection. And I think the mother of all sort of skin and soft tissue infection, including bone and joint infection, is diabetic septic foot. You've seen it a lot. And it is, if we talk about the pathophysiology of it, there is motor neuropathy, which leading to the foot deformity, and then the abnormalities. And you also have a sensory neuropathy. The sensory neuropathy will lose a sensory protective sensation, as you know, as well as you have the autonomic neuropathy, which is caused by dry skin. All this combined will produce an area deformed where the pressure is and where the infection effectually start. And I'm sure all of you have seen in and out cases like this patient with poor diabetes control, significant. And as you can see, all I talked about, this deformity, what you see it around the ferrous hallux, and then you develop the infection, and the patient with poor, and unfortunately, at many, this patient, when they present late, always it's problem. So it's always to treat this patient early, as I will show here actually. The cost to the patient to the left-hand side, patient at risk of diabetes on the x-axis, and the y-axis, the healthcare cost. So when you develop infection, followed with osteomyelitis, and then you have the vascular surgeon and you have the orthopedic for amputation. The cost to the health system and the cost to the patient are very high. So that's why it's very important for the diabetic septic food to set your MDT very functioning, and you have your pathways, which is include everybody: the diabetes endocrinology, the podiatry, general surgery, vascular, orthopedic, and unfortunately, without leadership in any healthcare, problem with diabetic septic foods will continue. And it's very difficult to convince people actually that late things can cause significant sort of loss to the healthcare, and the better to attack the problem. And in myself, this subject was being close to my heart, and I tried all for a number of years actually to try to shift it to the left, which was difficult. Um, I'm sure many of you seen cases of neck or necrotizing fasciitis. Since I was a fellow, actually, I was very interested in the condition, the polymicrobial, which is type 1, and the type 2, which is associated with gas. In type 1, which is polymicrobial, 70% association with diabetes. Increases susceptibility to infection, impair cutaneous wound healing, and have a major impact. And you've seen the Fournier gangrene, which is happen in the genital area. Significant morbidity and mortality most usually have medical and surgical input. And people think the glycosuria, especially if there is poor hygiene in the genital area, is a major predisposition for patient with Fournier gangrene to develop necrotizing fasciitis in that area, because the hyperglycemia shedding of the glucose eventually provoke the develop of an infection. During my search, it was very interesting. I came across this FDA warning. It even skipped me in 2018. That is showing that in patient with SGLT2, glucose transporter drugs, there is increased incidence of necrotizing fasciitis and Fournier gangrene. Eventually, that has been withdrawn, but I was trying to convince my diabetes and endocrinology colleague, as well as our fellows, to try to look at our cohort of patients who was using this oral hypoglycemic, which is promote the secretion of the glucose through the renal glomerulus, to see whether it will increase maybe predisposition to UTIs and skin and soft tissue infection like necrotizing fasciitis. Every now and then, you will see a lot of patients. I frequently see this problem with, as you can see, and of zoster, and you have to screen for immune suppression, and among them is diabetes. And again, from meta-analysis, patients with diabetes are at increased risk of development of zoster, multifactorial cellular dysfunction, reactivation of the virus because of immune dysfunction, very, very well documented. So we covered a lot of things. We covered the skin and soft tissue infection, bone infections, and now we come into respiratory infections. For example, we're coming to pneumococcal disease. Both morbidity and mortality are increased with the odd ratio almost doubling and sometimes even tripling actually in terms of patient. That's why it's an indication actually to give pneumococcal vaccine for patients with diabetes. As you know, the age lowered to the age of 50 now. I remember in my presentation last year about the age, and I postulated this actually before the CDC done their intervention, because patients above the age of 60 will be less likely to seroconvert for vaccination. So it makes sense actually to vaccinate elderly patients earlier actually, and that is to prevent them. And I'm glad actually eventually that is now being the recommendation that the pneumococcal vaccine should be above the age. And all your patients with diabetes, I would risk them, especially for example, on pneumococcal, to consider this early, because you have almost 2 times risk of developing either pneumonia or mortality from that. I'm sure you've seen a lot of patients with diabetes and UTI, and this is a very well taken home message about the association. But during my preparation of this talk, I looked at the classical approach of patient with diabetes have continuous glycosuria, for example, like SGL2, which predispose them to infection. Our diabetes group here said when they looked at UTI and SGL2, they mentioned they could increase UTI. But you assume because on the renal tract there is hyperglycemia, it predisposes patient to infection. But the modern approach, that is insulin, have affect the sort of signaling pathway for antimicrobial peptide. So if you do search about this antimicrobial peptide, and the idea in the antimicrobial peptide secreted in the renal tubules, and they are down-regulated by insulin, and they bound to the pathogen and prevent them from causing infection. In patient with diabetes, this mechanism is disrupted, and that will make patient with diabetes as increased sort of susceptibility to infection. And in this study, actually, diabetes down-regulate antimicrobial peptides, psoriasin, and increase E. coli burden in urinary bladder. So this quantitatively, this group, they showed that this is antimicrobial peptide. When it is deficient, there is increased quantization of the E. coli in the urinary tract. So what they are postulation that the high, glucose concentration induce lower psoriasin levels and impair epithelial barrier function, and that is predispose people to UTI. Again, an area for investigation actually, and I can be suggested to any group with universities, so just to look at patient with diabetes and you have a control group to see whether there is this antimicrobial peptide present or absent in this group. So I think with that, I have clinical cases. If you want people to stop now and discuss the science, or I can continue with the clinical part. I have like 4 or 5 clinical scenarios to link the theory to practice. Izzeddin, do you want me to continue or do you want to take question now?
Yeah, I think if you continue, that would be great. Yeah.
Okay, okay. I'll continue. So I gave you the theory, the susceptibility to infection, and we discussed the pathogen, we discussed the host and the environment in less concern. But I think you will be interested in looking into what is the application of what I already said in patients with diabetes. So in the first case scenario, we have a 64 years old male, heavy smoker with newly diagnosed diabetes type 2, hemoglobin A1C 10. Recent admission, he had a sixth nerve palsy. They thought it was a stroke and he was treated accordingly. But he came to ED with an acute symptom of fever, cough, and hemoptysis. Chest X-ray showed right hilar or upper lobe shadowing. He initially treated as pneumonia and planned to do an outpatient CT because of this chest X-ray. As you can see, cough, fever, hemoptysis, and you cannot blame sort of most ED in different countries will do the same thing. They think the simple thing, they give patient antibiotic and to do a CT scan. But what happened? The patient deteriorated before the CT scan was performed, worse with weight loss, severe cough, and worsening hemoptysis, readmitted. The medical team were fixated in, and this is again diabetes, hemoptysis, weight loss, shadowing. Either he had a cancer, heavy smoker, either he got a cancer. As you can see, there is a very big sort of consolidation right upper lobe, maybe in the left-hand side, that is in the CT scan in high resolution. They've done bronchoscopy, abnormal, there is external compression, but apparent BAL tests were negative. So they've done the BAL negative cytology, bacterial, microbiological culture, TB studies, including TB PCR. They didn't take samples for histology, which would have been interesting. As you know, most time our sort of pulmonologists usually don't do a histological examination unless there is sort of protruding lesion or thing. But before anything happened, he has a massive hemoptysis, which is prompted emergency embolization, followed by partial lobectomy. So this patient went to the cardiothoracic, they done lobectomy. And in fact, actually, we've seen him in the ID clinic because of the histology. As you can see here, infiltration with lymphocyte, granuloma cells. And this is what is shown in the histology with the general stain, and this is by using the crocot or the silver stain. Anyone want to shout a suggested and diagnosis before I go to
Baker?
mucoria? Exactly. Yeah. So Aggressive fungal infection, three main forms, as you know: rhinoorbital, cerebral, pulmonary, and cutaneous. Frequently mistaken for TB or neoplasm, especially for the pulmonary disease. It's a well-recognized association with poorly controlled, and I will explain to you why is that. The mucor, the fungus, utilize iron in Fa3 rather than Fa2, which is best converted in acidic milieu. So when patient, especially that's why patient with DKAs, uh, they have cutaneous mucor, and again here in pulmonary. So the poorly controlled, the lactic acidosis increase the ion conversion. And as you know, mucor is angioinvasive. That's why the hemoptysis it become, and it follows the blood vessels actually. And maybe actually on that bronchoscopy, the compressing region was the mucor was coming from outside, compressing to the inside. And we treated this patient with ambisome, and then we gave him posaconazole. And actually, in our recent review, isavuconazole actually is excellent for tutor treatment of mucor. If you want to include it, we gave patient 12 weeks. People can go for 6 months. And as you know, in mucormycosis, the best thing is surgical and medical. So this patient come to us surgical just because of the hemoptysis, the massive hemoptysis. So the second case, diabetes and abdominal pain. This is a 46-man from Bangladesh, admitted to hospital, 3-day history of fever, chills, progressive right upper abdominal pain. So he was very toxic. As you can see, temperature 39, respiratory rate 33, saturation 98, heart rate 150. He was tender right upper quadrant. YSL 20, CRB 300, procalcitonin 95, abnormal liver function test, blood glucose were very high, hemoglobin A1C 8.8. So this patient toxic. So I will put the X-ray here. As you can see, there is a very combined, mainly sort of infiltration in the chest. But anybody can spot any other abnormality in this plain chest X-ray? You can shout anything, or I will proceed here.
Like there is a cystic lesion on the right side, or
Excellent. Yeah, as you can see, should be the liver. Okay, so the liver should be compact because this is a diaphragm. So there is something sort of under the liver, which is it could be like a cyst, but as you can see, this is a very big abscess with a gas formation. So what transfer almost one half of the liver has been transformed, and there is also pleural effusion, very toxic sort of presentation. Admitted to ICU, fluid resuscitation, insulin infusion, followed by broad-spectrum antimicrobial. The liver abscess was aspirated. Blood culture was also positive for Klebsiella pneumoniae. The same organism from blood culture and the urine, so he got disseminated. Deteriorated while in ICU with respiratory compromise. The CTPA showed septic emboli. So all this pathology you see in the lung were septic emboli. It didn't finish there. Uh, Fever did not remit as anticipated. Then a PET scan, and as you can see, infection everywhere. He got infection in the gluteal, in the intra-abdominal, treated with 8 weeks parenteral induction, followed by maintenance to safe outcome. So this patient discharged well, actually. So this is a disseminated biogenic gas-forming liver abscess, very rare. You must
Had
have seen the other
endocarditis.
part. Say it again.
Sorry, did he had endocarditis as well?
No, we've done echo actually. As you know, gram negative, it is usually rare, but we've done echo. No, but eventually we became pragmatic because we're treating him for 88 weeks anyhow. And you might see the resemblance of this with inflammatory pyelonephritis, which is again happened with E. coli or Klebsiella in patients with diabetes, mainly because of the hyperglycemia. Okay, so this is a gas-forming biogenic liver abscess, the same pathophysiology as I mentioned of inflammatory pyelonephritis. It is a susceptibility of infection in the context of diabetes, and the gas formation because of the high metabolic rate. And in my search, actually, I found there is a special, um, serotypes of Klebsiella in KL1 and KL2, I'll show it in the next slide, are associated with this condition. And biogenic or gas-forming liver abscess and in biomatous pyelonephritis, 95% association with diabetes. So it's always happen in patient with diabetes, high morbidity and mortality, and best treated with surge control as we been on prolonged antimicrobial. So these are rare condition but very aggressive. And as I mentioned, there is a sort of studies which showed that the virulence or the capsular serotype of K1 and K2 of Klebsiella in type 2 diabetes was brought by predisposed patient to this condition. And as I mentioned to our fellows, actually, we usually save blood cultures for that patient, although we reported the case as a case report, but we have the culture. We can do whole genome sequence to look for this Klebsiella, whether it have a specific virulence to lead to this devastating infection. The third case, and I'm sure.
معلش Ahmed, can I ask a question? Do you
Yes,
recall
you can.
do you recall the susceptibility profile of this Klebsiella? Could
It
it
was
be like
sensitive, to be honest. It wasn't resistant.
it was
If I
sensitive?
remember correctly, it was sensitive Klebsiella all the time. So it
Yeah,
was
that
from the
looks like a
urine.
hypervirulent
Hypervalent,
HPHS.
exactly.
Yeah,
Yeah, our
yeah.
colleague Clement and our one of our fellows, they've done studies in hypervalent Klebsiella in our cohort. So in retrospect, I completely agree. This is most likely to be a hypervalent Klebsiella, the very well recognized cause of causing severe disease. So as I mentioned, if we can revisit that by doing whole genome sequence to look into that. And hypervirulent Klebsiella, as you know, it's cause high morbidity, mortality, and maybe even death. Yeah. So diabetes and EREC, we have a 63-year-old with long-standing type 2 diabetes with retinopathy and dyslipidemia as well as hypertension. Drug history included insulin in addition to lingagliptin and pyrindapryl and rosuvastatin. 1 week history of right-sided earache and vertigo. So whenever you see a patient with diabetes with earache, always take that very seriously. And you have to be aggressive in the investigation. In the ear canal, it was normal, no discharge, tympanic membrane was normal, the partial six nerve palsy. So this patient, actually, I saw him when he came to ENT treated with antibiotic maybe for 4 or 5 months. All our previous ID colleagues were pushing ENT biopsy, biopsy, biopsy. And as you know, we always have this fight with surgeon. They don't have our, sort of mirror or lenses to detect infection, because whenever you have diabetes with deep-seated infection, you never know what you're going to deal with. So this patient has significant brain stem disease, involvement everywhere. That is documented in the CT scan, in the MRI, in the PET scan. And when he came to me, maybe 4 or 5 months, I insisted with ENT to try to biopsy him. And as the CT scan demonstrated thickening of the external auditory canal in the middle ear with ill-thinned soft tissue mass pacifying the right mastoid air cells. MRI showed extensive diffuse multi-compartmental enhancement with bone involvement suggestive. So he got bone stem osteomyelitis. And when you read this, you already know the condition, malignant otitis externa, but 90% association with diabetes, hyperglycemia, lower immunity, and just many of you might see Pseudomonas, but I try to give you, explanation for the Pseudomonas. The cerebellum or the earwax in patient with diabetes is very acidic. Okay, pH might be as low at 4 or 5. So many bacteria will not be able to withstand this high low pH. Pseudomonas can. It can cause biofilm formation, and it's very well known to be resistant to acidity. And that's why the association with diabetes and Pseudomonas is very high. So malignant otitis external and diabetes and Pseudomonas, again, the same like E. coli and Klebsiella and UTI. This is goes hand in tandem, okay? So frequent complication, you must have seen many sort of people presenting with neurological 6 nerve palsy or 12 nerve palsy involvement of the sort of brain stem, very common. When it goes into the brain stem, then it's very difficult. And as you know, you have to treat this patient aggressively, 6 to 12 weeks, in our case, actually, it was a fungal infection. It was a candida infection, again, significant morbidity and mortality. And this is, you should always do that actually. When you give antibiotic, the patient is not improving, you have to biopsy the patient, okay? So I think this is the last case, an interesting case. Uh, 57 Qatari patient, background of diabetes and hypertension. He went to Thailand, but he's only 57, but he got diabetes, hypertension, sudden right-sided stroke during the first week, admitted to local hospital for 4 days, and then he sustained right-sided leg wound while going to the toilet in the resort. We knew that afterwards, and that is the importance of visiting the history, because the patient came to us with fever and positive blood culture. We will talk about that. But he also was in the resort. He used hydrotherapy, and I will show the link to that. When he came to Doha, actually, he admitted directly to ED. Because it was recent stroke, they've done the stroke sort of protocol, CT, carotid Doppler, coronary infarct, conservative management with secondary prevention, because it was more than 2 weeks from there. But he was noticed to be febrile 39, as I call it. We just finished the sort of case report of this case, fever in return travel, okay? And his CRB was high. His chest X-ray was shadowing. So ED thought he might have what we call it hospital-acquired pneumonia because of his recent hospital admission. But his blood culture was positive, okay? And when we examine him, as I like actually fever of unknown origin, actually, because you have to take history well and you have to examine the patient. And we've seen this port of entry, and I give this clue actually. Patient visited Thailand with blood culture, with lung involvement. Anybody want to shout a potential diagnosis?
Porphyria?
Burkholderia, exactly. Yeah, excellent. So rice baddies, Burkholderia is environmental. I remember Nicholas White. At the first time I heard it from, he's a professor, he's a Wellcome Trust, when I was working in Oxford. He's the first time, and at that time he mentioned ceftazidime and meropenem, as I will mention it later. So it is an environmental in the water. It goes through skin cuts and it causes septicemia. Very strong association with Thailand. Almost 80-90% of reported cases from Thailand. So it must be this is the environment, which I didn't thought of talk, but it's very common in Southeast Asia, in Australia as well. So there is port in Australia, as you can see. And what is actually, although I'm an experienced ID physician, I've seen at least few cases of Burkholderia. This is strong association with diabetes, actually. A lot of studies reported very high odd ratio with diabetes. And as I mentioned, because intracellular, the same like TB. So this patient is diabetic. He had a skin cut. He had hydrotherapy, port of entry, secondary Burkholderia. And as you know, this patient, we treated this patient with 2 weeks induction with meropenem and then followed by cotrimoxazole. Afterwards, we treated him, I think, for 2 months, if I remember correctly. So I think, I hope in this sort of journey that I managed to convince you in clinical services to raise awareness of the importance of infectious disease in the context of diabetes. And this should be awareness for both senior and junior team meeting. And then we have to try to address gaps in the diabetes services, especially diabetic septic foods, through MDD collaboration and education and training, very important. And there is a lot of training opportunities in this co-infection of diabetes and infection. But also we have to concentrate, I think from the presentation, a lot of innovation and research, basic clinical research in the interface of diabetes and infection. We can look at the hypothesis. I tried to convince our colleague in population medicine in Qatar University, but this is a big project to look at the hypothesis of viral infection as a potential cause of diabetes. TB and TB and it's very well established, but you might look at other venues, TB and vaccination, diabetes and vaccination, diabetes and TB, diabetes and immune dysfunction, and then an UTI. Again, this is again you can do a lot of studies about UTI, as I mentioned, looking at the inflammation. Many these investigation sort of cases, we transfer them to many publication in case of the pulmonary mucormycosis, gas forming biogenic liver abscess, and the candida. And it's a great for junior colleagues as are attending. Actually, we develop knowledge by reporting these cases because you go and investigate and read more. So I hope I managed to deliver in this hour actually the interface of diabetes mellitus and infectious diseases closely related based upon the host factor, immune dysfunction, and susceptibility to infection, coupled with specific pathogen characteristics. And there is mounting evidence that diabetes mellitus might be triggered by an infectious agent in susceptible host. I hope I live to prove this theory actually, and which will have a huge public health implication. And the multitude of systemic infection specifically related to diabetes that should be recognized. An MDT approach is very important. TB, skin and respiratory tract infection are merit both screening of to preventive strategy. As we ask our diabetes team, do you screen your patient with diabetes for TB? And they said no. So we try to develop actually a research and then a protocol to see whether that is possible. And there is huge potential for research and development of joint, between the two specialties. Thank you very much.
Thank you, Hamad, for the excellent and insightful presentation. The floor is open if anyone has any question.
Shukran, Hamad. With regard to other intracellular bacteria like Salmonella, was any evidence that there is more increased incidence in diabetic patients?
I remember we looked in a previous research in Salmonella. I don't remember specifically to see association between Salmonella and diabetes, if I'm correct actually. But as you know, if, for example, if you develop bacteremia, patient with diabetes will be at increased odds of developing increased morbidity and mortality. So, but I couldn't find specific connection between, as far as I remember. Yeah.
Thank you, Hamid, for a very exciting talk. It looks like diabetes is an infectious disease now. So
It should be, yeah.
I think there is a lack of cooperation between endocrine and infectious disease. Number one, diabetic foot infection should be a management between both an infectious disease and orthopedics or podiatry, if you call it, because the outcome will be better in that case. I mean, the number of amputations will be much less in areas where you have both an infectious disease and podiatric clinic. The other thing is that there is a complete lack of consideration for vaccinations in diabetics. I mean, I think we need to be sure they are vaccinated annually for their influenza. They might need the pneumococcal vaccine and many other things. What I find interesting in your talk is the mucor and diabetes and TB and diabetes. A nice case you presented with mucor affecting a diabetic, but we had a case actually who had both mucor and TB at the same time. Patient who had a trauma, he developed like a necrotizing fasciitis, and the biopsy showed acid-fast bacilli and showed the high view of mucormycosis. So these are important considerations in diabetic patients. But thank you very much for the interesting talk. Thank you.
Yeah, thank you, Fathi. Regarding the first point, we have a very major diabetes and endocrinology department here in HMC in Qatar. Yeah, lots of research and publication. And actually, this talk I was trying to entice them to collaborate. Yeah, and when I looked at their publication of the interface of infection, I found no work. Okay, which is again, as you know, these things need leadership and it needs somebody to direct people to the right direction. So although, as my colleague Ali Sultan from Weill Cornell Medicine Qatar mentioned, if you look at the complications, this is a natural history of disease. You have to look at prevention before that. How can you prevent things like screening of patients with diabetes for TB? So all these things, I hope actually some of them will listen to what I've been telling them, to try to direct their research in rather than metabolic into joint collaboration with infectious disease. But as you know, all these things need a lot of convincing. Regarding your joint case, yes, it's very interesting. And the association with diabetes and TB very well established, and mucor and diabetes also very well established. And mucor, as everybody knows, this is environmental. One of our colleagues from Saudi Arabia recently showed us a patient with extensive skin mucormycosis, and basically he was having some leg pain and things, and he was rubbing his skin with some mud or something, and eventually developed extensive mucor, and he was diabetic. Okay, so mucor, always be very careful with environmental exposure.
Thank you,
Anything
Hamad.
else?
One comment about pediatrics also. A lot of time we see also kids when they present in with unusual infections, we screen them for diabetes, and sometimes that will be the first time we diagnose them. We had, like, in the last few years, a child presented with persistent ear infection and end up growing a chromobacter from the culture, and we screen him for immunodeficiency, including for diabetes, because they have family history, and he had type 1 diabetes. So I wonder, in the adult world, how um, are they any similar presentation in adults? Like the infection will be the first presenting symptom for diabetes or sign for diabetes?
Yeah, and type 1 diabetes is very common for us when patient come with type 1 diabetes to screen them with infection, blood culture, urine, and chest X-ray, because usually it's an infective cause which is make them present to hospital. So it's a very common scenario. And as you already mentioned, whenever you find the weird on the wonderful, if you have a specific bacteria unlikely to cause infection, you have to think about other sort of causes of what driving that, and among them are diabetes. Yeah.
Hamad, thank you very much for the presentation. It's triggering many thoughts, you know. As you are presenting, started to remember the usual recommendation from David Jenkins during our microbiology rotation, when he used to ask us for any E. coli bacteremia, you must include hemoglobin A1C in your advice, apart from, look for a source, send urine culture, examine the abdomen. The thing which I really wanted to share from mycology point of view is recently in a small hospital, a DG hospital in the UK, which is 500 beds, we've seen 3 cases of Candida bloodstream infection. Under urology, the 3 patients were diabetic. The 3 patients underwent urology procedures. They were all on SGL2 inhibitors. And we talked to Annie Joseph in Nottingham, because that was like Candida infection within the urinary tract is her area of interest. And she shared the same observation, like those who undergoes urology procedures on SGL2 inhibitors, the incidence of Candida bloodstream infection is high. So yeah, that's an example of bacteriology. This is a thought about mycology. And the last is from virology, where the rotavirus association with autoimmunity, similar to what you mentioned about molecular mimicry. There was a study in Australia where they noted that there was 14% reduction in the incidence of type 1 diabetes, comparing 8 years before starting rotavirus vaccination and 8 years following implementing rotavirus vaccination. And they tried their best to rule out any change over the time in intervention patterns. So this is my observation. Well, thank you very much. Your presentation triggered all these thoughts.
Thank you, Sam. Yeah, it's very interesting. Actually, I remember Michael from Boston. He's a very sort of renowned ID physician, immunocompromised. He was interested in Candida, and I remember he gave us a presentation a few years ago in impaired of phagocytosis of Candida in patients with diabetes. So, as already mentioned, fungal infection is increased in patients for multifactorial. But the SGL2 and Canada, again, very interesting actually observation from your side. I will try actually next year to give one of our fellow a project of looking at patient with SGL2 and infection. So he can look at on aspect, including UTI, skin and soft tissue, and maybe sort of fungal infection. But it makes sense because this agent increases, renal tract glucose excretion, which is a predisposed to infection, as well as increase affect the phagocytosis of immune cells. So most likely the secondary bacterial or fungal infection is all plausible. Yeah.
Hamad, Assalamu alaikum.
Salam يسري كيف حالك؟
Thank you so much. That is fantastic. Usama beat me to the Australian study. Where do you think you draw the line between causation? I mean, infectious diseases are just so many. You told us about a few today. We just mentioned the rotavirus. When these are just too many, they cannot all be causing a problem. So I always thought inflammation that is triggered by an infection is probably where these wonderful pathways and interactions at cellular level and at a molecular level occur, rather than a infection or a pathogen per se, a single one. And we cannot, of course, control all infectious diseases in order to stop diabetes. So do you see it as dichotomy? One, something that triggers diabetes, but after that, once a person has got diabetes, then they will be prone to have infections. They think that we all know, and possibly the reason why people are not so much interested in this area, despite your, cajoling and pushing them to do more, because clearly a lot need to be done. Last night I was on call, Hamad, and we had a cardiac surgeon working in our institute, coming back from Pakistan, where he went for a funeral or something of a relative. He stayed there for 10 days and he came back and he was coughing and he had a fever, and the fever wasn't high, it was like not very high, maybe 37.9 or something like this, and he had got bilateral pneumonia. Lobar pneumonia is bilateral though, and following a minor viral infection he started in Pakistan. However, his hemoglobin A1C was 8, and he did not know that he was diabetic. So this is just another case to add to your collection and to the point that Usama made about the E. coli. I don't know what I'm sure it's going to be a pneumococcal pneumonia, although it's bilateral and everything, but it's quite massive one. And he did not know he was diabetic, and he's got no other risk factors, probably just a bit of smoking, and that's it. Thank you, Hamad, for the call.
Yeah, Yusri, yeah, to come from the first part, if you study the pathophysiology of type 1 diabetes, as we all know, we call autoimmune disease caused by the depletion of the pancreatic beta cells. And in the histology is always inflammation with lymphocyte infiltration and destruction of this sort of cells, insulin secreting cells, insulinitis. So that is a disease, okay? So I'm just trying to separate type 1 from type 2. So it makes sense that there is an infectious agent, maybe specific one, which is led to the development of autoimmune, and then the insulin secreting cells are the bystanders. That is logical. So there must be an infectious. And unfortunately, you need a very large observational study. What I'm proposing, Yusri, you can also do that in KSA, on all patients with, and I'm trying to develop link with we have a very clever transitional research institute. In patients with type 1 diabetes, you can do a lot of genomics, metagenomic study to look at agents, potential agents, which is you can explore this theory afterwards. So this is type 1. Type 2 is different. So type 2 is the genetic susceptibility. There is an infectious condition causing, because in type 2, you will see patient, this chronic inflammation very well described. Okay, they have increased, cytokines in type 2, which is lead to insulin resistance. So what will trigger type 2 is maybe multifactorial, maybe difficult. So I think scientists should concentrate first on type 1 to try to find an infectious agent which is cross-react with the pancreatic B cells, leading to insulinitis, leading to insulin depletion. And then they can tackle type 2 in a different way. And I came across the rotavirus, and maybe I didn't include this sort of the slide in my presentation, but there is so many, bacteria, so many, and this is all observational studies. Needs somebody, but needs, people in public health, in population medicine, to invest time to try to investigate this potential pathogen. As of your second case, it's very common for us. Asian population is again very interesting. You will see them lean people, and they develop type 2 diabetes. Again, they must be genetic susceptibility. They might be dietary, as people mentioned, sort of the Western diet, different from the vegetarian diet which you used to. And we see it very commonly. And even they come with cardiovascular complication in their 30s and their 40s, massive cardiovascular and cerebrovascular disease. So it's not a, maybe it surprise you, but to us, it doesn't surprise us at all, actually, to see Asian patient with diabetes, yeah, because of just of the sheer number, yeah.
Hamid, I was only biased for the rotavirus because I like the idea of vaccine preventable autoimmunity.
Mm. Yeah, yes, it's a point actually. I will go and dig that study actually because um, um, again, if you think about it from a scientific point of view, you would try to find a pathogen, then you can have a vaccine, and then maybe you sort of to try to prevent at least in susceptible individuals to prevent that. But it is, I think, I'm convinced most likely that is the way, because a lot of things which we, as I already gave them the example of ITB and TTB, now you have an explanation for them. Maybe just the science is not strong enough to prove this for diabetes for the time being.
All right, if there is no more question, we conclude today, and thank you very much, Dr. Hamad, for the excellent review today and cases. And we hope to see you all next month, inshallah.
Thank you very all for attending. Appreciate it. And thank you, Azadin, for the effort of putting this meeting together.
Thank you, guys. We'll see you next month.